Okay, now that we've talked about nerves, let's get into the nerves. But I would like you to know this will not be as comprehensive as you may want. All of the details will be covered in the hand core webinar. And the reason is hand very much is involved with these peripheral nerve compression neuropathies. But for me, I take care of athletes and I take care of a lot of elbow patients, and cubital tunnel is something that is very common. It's worth knowing. So compression neuropathy of the ulnar nerve is what we call cubital tunnel syndrome. There's various sites that can compress the nerve. It's important to know them. Between the two heads of FCU, which is right here, the arcade of Struthers, which is most proximal, and Osborne's ligament is the tissue that goes over the so-called cubital tunnel, and it's right behind the medial epicondyle. Less common sites of compression are the medial head of the triceps. Having said that, in my practice, I take care of a lot of throwers and athletes where if they start working out and develop a lot of hypertrophy of their triceps, they can get ulnar neuritis from that. So everything's about anatomy. The triceps is adjacent to the nerve. If the triceps gets enlarged, then you can have you can understand that neuritis would happen. So all of these questions, by knowing anatomy, you can deduce clinically what would happen. Makes you a better doctor, going to help you get these questions right. The patients, when they have a real neuritis, will have pain and tingling in their fingers, and as they get neuropathy, they will get more permanent loss of sensation. And the region, as you see in the blue here, the ulnar nerve distribution is the fourth and part of the fourth and the fifth finger. So I ask every patient who's a thrower to get tingling in your fourth and fifth finger as an example. And some activities can exacerbate the symptoms. So the flexed elbow position, holding your hand to your ear, for example, throwing a baseball, those are associated with the ulnar neuritis. And you can get it at night, or you can get it when you're sleeping on a plane. When you sleep, you bring your elbow into a flexed position, and as you know, the flexion at the elbow will increase the pressure on the ulnar nerve. It'll exacerbate the symptoms. Physical exam will reveal atrophy of the intrinsic muscles, especially in the first web space, and when you have motor issues, you will lose the motor function and have clawing of the fingers, as you can see here. This is a very classical photo of a long-term neuropathy. And here, this is even more advanced neuropathy. And on exam, these patients will clearly have weakness to grasping and pinching. And the Frohman sign is interesting. That's a compensatory flexion of the finger. So instead of when you go to flex your finger against your index finger, you will cause your finger to flex instead of being able to adduct it. Your adductor will not be working. So that's a classic sign. That's probably the most fun to test on and will show up in your exams. Let's move on to pronator syndrome. This is the median nerve compression neuropathy at the elbow. So this one will be covered again in more detail in the hand core webinar. But I do see this clinically. I do see it in throwers and other athletes, so it's useful to know. Pronator syndrome, median nerve at the elbow. The muscles around the forearm, the pronator especially, if they become overly developed, just like the triceps on the ulnar nerve, these muscles become overly developed, they can cause the compression. You also have local anatomies such as the supracondylar process and the ligament of Struthers that can also cause an entrapment site. And you can see that here is a characteristic X-ray finding of that type of anatomy that will compress the median nerve. So the symptoms in this case are thumb, index, middle finger, and radial half of long finger. We're very comfortable with the median nerve, especially as it relates to carpal tunnel syndrome. But you should be able to differentiate this clinically from carpal tunnel syndrome. How do you do that? Well, the patients complain of aching pain over the proximal volar forearm. They'll have sensory disturbances over the palmar cutaneous branch of the median nerve. So this will be a little bit higher up than classic cubital tunnel syndrome, and they don't typically have night symptoms like cubital tunnel syndrome has. The provocative test is tenell over the proximal anterior forearm, but no tenells that are more at the wrist. That's basically the biggest difference, and that's the highlighted area that could be tested. Let's move on to radial tunnel syndrome. And I do like studying the nerves. If you study the nerve anatomy and you know your nerve anatomy, it will help you with all kinds of aspects of getting test questions right. It'll also help you, especially with surgical procedures. So spending time on nerve anatomy is really important, and I review it on a regular basis myself. So compression neuropathy of the posterior interosseous nerve is usually pain only. You don't have muscles that become weak, and it's related to compression at different sites. This is worth memorizing. The pathophysiology of radial tunnel syndrome is compression at the fibrous bands of the radiocapitellar joint. The radial recurrent vessels, favorite test questions. I think I had that test question on one of my exams. The medial edge of ECRB and the arcade of Fros. So, and then the distal edge of the superficial layer of the supinator. So you see this anatomy here. These are all of the compression sites, and this is very much worth memorizing. Again, deep aching pain, dorsal radial proximal forearm. This can also simulate lateral epicondylitis, and so it's a little more distal in location, and they also can happen in combination, where you can have radial tunnel syndrome and lateral epicondylitis. So there's tenderness over the muscle extensors, just a little bit more distal than where lateral epicondylitis would be. You could have symptoms exacerbated with resisted long finger extension. Resisted supination test was with the elbow and the wrist and extension, and passive pronation with wrist flexion. So that's a passive stretch in the area to try and elicit symptoms. And then here's something very important. We do this in nerve conditions regularly. If we need a diagnosis, we can often do a selective diagnostic injection. Inject the area and see if it relieves pain, especially in certain conditions that require a clinical diagnosis. Let's talk about flexor pronator strain now. We went over this a little bit with the medial epicondylitis, but this is more when you have an acute event and you have an injury to that area just distal to the epicondyle where the tendon attaches. I see this quite frequently because I take care of a lot of throwers, and throwers get this frequently. The physical exam is tenderness, provocative movements, as we said before. These muscles are for wrist flexion and finger flexion. You clench the fist, you flex the wrist, that will elicit the symptoms, and also pronation. And make sure we understand the differential diagnosis, which is local anatomy, UCL injury, and we spoke about medial epicondylitis already. This is what an MRI scan looks like. This is a signal. Before we saw epicondylitis over here, now we're seeing signal in the flexor pronator mass. This is a pretty dramatic one. This is a patient of mine. This is in a thrower. So the non-operative treatment includes a period of rest, modalities, physical therapy, like any other muscle strain. We have to be careful, especially in the throwing athlete. They may have a UCL problem, and we certainly do not want to inject cortisone into the UCL that could weaken it. For those that are torn and have retraction, especially in athletes, we recommend primary repair for the tear.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.